Good day to doctor and friends. We are from Group 1B. We would like to present our ambulatory care clerkship case. So basically our case is about a 66 years old female with a weight and height of 79 kg and 158 centimeters. She came to clinic primer PPKM for kidney checkup. She had hypertension, dyslipidemia, diabetes mellitus and CAD for 18 years, and she received tablet amlodipine 10 mg, tablet valsartan 160 mg, tablet bisoprolol 5 mg for her hypertension, tablet atorvastatin 40 mg for dyslipidemia, tablet metformin 500 mg, tablet glycoside 80 mg, tablet empagliflozin 10 mg for diabetes mellitus, and tablet GTN 0.5 mg, tablet isosobite dinitrate 10 mg, tablet trimetazidine modified release 35 mg, and tablet cardiprane for her CAD. Her father has hypertension and stroke, and she has no known drug allergy.
Clinical condition of this patient would be dyslipidemia, and the goal of treatment for this patient would be target LDL level will be less than 2.6 mol per liter, target HDL level will be more than 1.2 mol per liter, and target triglyceride level will be less than 1.7 mol per liter. Currently, the patient is being on tablet atorvastatin 40 mg for the past 18 years. As for the justification part, atorvastatin is the best to be given for this patient, as statin therapy was proven to reduce the cardiovascular events in the patient, especially in more than 40 years old patients with type 2 diabetic mellitus patient, irrespective of the baseline level of the LDL level. The lipid abnormalities in type 2 diabetes mellitus is very common, as it's known for having high plasma TG concentration and high level of LDL. Statin therapy should be considered in individuals with stable CAD, and there is a study that proven the lower dose of the atorvastatin in medium risk of hypertensive patient has shown significant level in reduction of the CV risk. And also, atorvastatin is the best statin treatment to be given for the patient, as it helps to reduce the patient elevated TG and cholesterol level effectively, as shown in the lab result of this patient. The current clinical condition would be hypertension, and the goal of treatment will be to achieve target SPP level, which is less than 140 mg in older patients, to avoid the cardiovascular complications. And the current medication list would be tablet amlodipine 10 mg, tablet valsartan 160 mg, tablet bisoprolol 5 mg. As for the justification part, amlodipine is to be given for this patient, as it's a calcium channel blocker which effectively known for its BP lowering effects and also excellent safety profile, especially dihydropyridine. It's known as a first-line antihypertensive treatment. CCB does not have any significant metabolic effect. They do not compromise any glycemic control in diabetic patient. And they can be effectively combined with any RAS blockers to lower the blood pressure in hypertensive patient, together with having diabetics as well. And long-acting dihydropyridine such as amlodipine are preferred over the non-dihydropyridine, with the use of beta blockers to avoid the excessive bradycardia or heart block. Valsartan, it is known as angiotensin II receptor blocker, which reduces the complication of diabetic mellitus and reduces the progress of the kidney disease. It is also known as first ARB choice for diabetic mellitus patient in terms of cardioprotection. As for bisoprolol in hypertensive treatment, bisoprolol is a beta blocker drug that is becoming as a first choice for hypertensive patient together with the CAD and angina. Cardioselective beta-1 selective agents without in-strict symptomatic activity such as metoprolol and bisoprolol are recommended. Bisoprolol are known to control the symptoms of CAD. Moreover, bisoprolol does not mask any hyperglycemia effect, and there is a study to prove that bisoprolol did not change any blood glucose level, HbA1c, and no hyperglycemia observed in the patient. And overall, systolic and diastolic blood pressure of this patient was significantly reduced, especially in the case of non-insulin dependent patient.
For the management of diabetes mellitus in this patient, the goals of long-term therapy treatment goals include achievement of appropriate glycemic levels, that is to achieve a HbA1c levels between 7.1 until 8%. It is less like because this patient has comorbidities. The next one is to prevent any diabetes complications, including retinopathy, nephropathy, and some acute complications, including hypo and hyperglycemia. And the third one is to improve patient quality of life. This patient is receiving a triple therapy that consists of tablet metformin, tablet empagliflozin, and also tablet glycoside. So, if we were to refer these medications to the CPG guidelines, management of diabetes in obese patient, all of them are appropriate to be used. So, we'll start first with tablet metformin. It is the first-line treatment for obese patient because of its efficacy on blood glucose control, tolerability, and safety. Apart from reducing the HbA1c by 1.5%, The metformin is beneficial for this patient because it does not cause the patient to gain any more weight. The second drug is tablet empagliflozin. It is the second-line treatment for obese patient, and it reduces the HbA1c by 0.2 to 0.8%. Benefit of tablet empagliflozin in this patient is because it offers cardiovascular benefit, that is the reduction of blood pressure due to the osmotic diuresis without any compensatory increase in heart rate. Tablet empagliflozin also useful for an obese patient because it promotes further weight loss. The next drug is tablet gliclazide, 80 mg. It is a new generation of sulfonylurea and is more favored because of the concern for the risk of hypoglycemia in older patients with polypharmacy. However, for this patient, the patient HbA1c keeps on increasing from 7.4% on 4th of January in 2018 to 8.7% in 4th of January in 2019. According to the CPG, any patient that coming in for follow-up with triple therapy with a HbA1c of between 8.5 to 10% and a FDG 10 to 30 millimole per liter that is demonstrated in this patient, he may be considered to start with an insulin therapy, basal or premix once daily, and need to be continued the triple therapy.
Moving on to the patient's underlying condition of coronary artery disease. Based on the CPG guidelines Stable Coronary Artery Disease 2018, the management of the stable CAD is divided into two, which is the symptom control and prevention of CV event. The first choice of drug in relieving the CAD symptom is a short-acting nitrate GTN with the addition of beta blocker or calcium channel blocker. Therefore, we can see that the treatment regimen of this patient is following the clinical guideline as a combination of the GTN and amlodipine is the first line of choice in the management of stable angina. Next, according to the guideline, if the symptoms persist and do not resolve, the use of long-acting nitrate and trimethazidine should be added into the regimen. Therefore, this choice of drug also follows the guideline as the patient receives tablet azoxorbate dinitrate and tablet trimethazidine to control the symptom of CAD. Other studies also recommend the use of both drugs as add-on therapy in patients who remain symptomatic. Next, moving on to the prevention of cardiovascular event. Based on the guideline, aspirin 75 to 150 mg once daily shall be given into the drug regimen. In the patient treatment, she received aspirin with the addition of glycerin as it has been found to reduce the gastrointestinal effect. Moreover, the addition of ACE inhibitor or ARB should be considered especially in the presence of conditions such as diabetes and hypertension. The goal treatment of this patient is to relieve angina symptoms and improve the chest pain-free exertion capacity, and also to prevent the subsequent acute myocardial infarction, unstable angina, or ischemic sudden death.
Moving on to the pharmacist intervention, pharmacists can encourage patients on healthy diet by restricting the calorie intake of 1,200 to 1,500 kilocalorie per day, limit the total fat, saturated fats, minimal trans fat, and dietary cholesterol for the prevention and treatment of cardiovascular disease, reduce salt intake for about 5 grams per day with a diet high in fruits, veggies, and low-fat dairy products to lower her blood pressure. Next, encourage patients to do regular physical activities by doing at least 30 minutes per day of moderately intensity exercise and gradually increase the time to 60 to 90 minutes for long-term weight loss. Pharmacists can also advise patients to increase daily activities such as gardening and walking upstairs. Pharmacists may encourage patients to lose weight. The weight loss of 5 to 10% of initial body weight over a 6-month period is recommended. Encourage patients on self-monitoring of blood pressure and blood glucose at home. Pharmacists need to address the common side effects of drug therapy, for example, the genitalia and urinary tract infections caused by empagliflozin, excessive bleeding caused by aspirin, and dizziness caused by azoxorbate dinitrate. And lastly, monitor the effectiveness and safety of the pharmacological therapy received by this patient.
Moving on to the monitoring parameters of drug therapy, which is divided into two, effectiveness and safety. For hypertension, regular monitoring of the blood pressure is important to assess the effectiveness of drug therapy with target BP of 140 over 90 mmHg. As valsartan may cause hyperkalemia and deterioration of renal function, therefore, monitoring potassium level, blood urea and serum electrolyte, and serum creatinine is very important to assess the kidney status. Besides, co-administration of amlodipine with beta blocker may cause additive effect in lowering blood pressure. Hence, monitoring of the blood pressure and heart rate regularly is necessary. Amlodipine also may significantly cause peripheral edema. Thus, monitoring patients' weight and symptoms of edema is very important. As for bisoprolol, it may mask the symptoms of hypoglycemia. Thus, regular monitoring of glucose level is important in this patient. As for diabetes mellitus, monitoring of the blood glucose level and HbA1c is very important to assess the effectiveness of drug therapy. The target of FPS between 4.4 until 7.0 ml per L and HbA1c is around 7.1 to 8% as patient has comorbidities. Metformin may cause lactic acidosis in patient with renal impairment and elderly patient. Hence, monitoring of the blood urea and serum electrolyte and also the serum creatinine level is important to assess the kidney function. Sulfonylurea has risk of hypoglycemia and weight gain. Hence, regular monitoring of the blood glucose level and body weight is important. However, this effect is less with glyphosate. Empagliflozin may cause increase in LDL cholesterol level. Plus, combination of sulfonylurea and empagliflozin may cause dyslipidemia and hypoglycemia. Therefore, monitoring of the LDL cholesterol at least once a year and regular monitoring of the blood glucose level is important. Empagliflozin also may cause genital mycotic infection. Thus, monitoring of the sign and symptom of genital infection also should be conducted to this patient.
For monitoring parameter for the atorvastatin, first, as a pharmacy, we need to perform liver function tests before initiating the treatment and keep monitor the level periodically. If the increment of the ALT or AST is more than 3 times the upper limits, the dose should be reduced or discontinued. Second, pharmacy also need monitor the HbA1c and the fasting blood glucose level because atorvastatin can cause the elevation of glucose level by lowering the insulin secretion and sensitization. Third, pharmacy also need to monitor the platelet level and the blood pressure because atorvastatin may increase the hemorrhagic stroke, which is the bleeding in the brain, when there is uncontrolled blood pressure. From this case, we can see that there is a drug-disease interaction between the atorvastatin and the diabetic patient because atorvastatin may worsen the high blood glucose level in diabetic patient. For the coronary artery disease, for the GTN 0.5 mg, we need to monitor the heart rate and the blood pressure regularly. Second, we need to monitor the side effect of the drug such as hypotension, reflex tachycardia, dizziness, sweating, diarrhea and headache. For the isosarbate dinitrate, we also need to monitor the blood pressure and the heart rates because this drug can cause the severe hypotension. For the trimetazidines, for the monitoring parameter of this drug, we need to monitor the side effect of the trimetazidines, as this drug can cause or worsen the Parkinsonian symptoms such as tremor, akinesia, and hypertonia. And another side effect that we will also need to monitor, such as dizziness and drowsiness. We will also need to monitor the renal profile of this patient because the exposure of the trimetazidine will increase in the renal environment. So from this case, we can also see that the elderly patient is a special population when taking trimetazidines because in the elderly patient, the exposure of the trimetazidine is high due to the age-related decrease in renal function. Lastly, for the aspirin plus glycine, we need also monitor the blood pressure, blood glucose level as the concomitant use of the aspirin with metformin. Second, we also need to monitor the side effect of the aspirin, especially in elderly patients, because aspirin will cause the nausea, anorexia, and the gastrointestinal irritation. So the drug-related problem that related with the aspirins or cardiprins, we can see that there is a drug-drug interaction between aspirin and oral hypoglycemic agent, such as metformin and glycosides, because this interaction will increase the risk of the hypoglycemic in this patient. And the drug-drug interaction severity is major. Second, interaction between aspirin and GTNs, because this interaction will increase the nitroglycerin in concentration and additive platelet function depress.